Today we're going to talk about when does TMS therapy start working. With me today I have Dr. Kevin Murphy. Doc, can you tell us a little bit about who you are?
Thanks, Kyle. Yes, I'm an oncologist by training, specializing in pediatric and adult brain tumors with a process called radiosurgery. And the last 10 years I've spent time working on a personalized approach to transcranial magnetic stimulation.
How long does it take for TMS to start working on somebody?
Well, in standard TMS, usually fairly quickly in the first week, patients notice a benefit. There's a dopamine release that's caused by electrical stimulation to the brain, which causes improvements in function in some patients. So in PrTMS and personalizing the approach, we see it work faster because we're not fighting the system. We're not trying to push the system to a new waveform. Not all patients are 10 hertz, which is standard TMS. 9.8 to 10.2 is about a third of the population.
Okay.
So a third of the population will fall in that zone of 10 being appropriate with standard TMS. The other 2/3 of the patients are not.
Yes.
They're below 9.8 or above 10.2 in terms of their frequency. If I then chase after their more native or resonant frequency, we see a faster response. So probably in some cases, it's half our patients are going to tell us in the first day or two they saw a difference.
Right.
And what they see is sleep improvement, anxiety reduction. The fast neurons come down quickly, and so anxiety goes down first.
That's exactly what happened with me.
Yeah.
Yeah.
So you saw some anxiety and improved sleep.
In the first night.
Yeah.
The sleep, TMS sleep is what I call it. That first night was amazing.
Well, there's two things that are happening. The first is you're taking down the high energy neurons to a slower speed and taking away the physical anxiety. You're also bringing the slow neurons up to a more usable speed. And those are the neurons you're putting on a treadmill. They've not been going 10 hertz or 10.5 hertz for years in some cases. And you just put them through 20, 30 minutes of, you will go 10.5 hertz. I'm going to make you do it with the magnetic field. So in those cases, when you take off that magnetic energy, the system goes, whoa, 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 whoa. We've been over here at 4 hertz for a long time. We're going to all go back there. We beat 4 times a second, not 10 times a second.
Right.
And you get this big fall off. And lots of our patients will say they feel tired at that first week especially. That's a good sign. I tell patients that's a good sign that you're responding.
Okay.
The system has been charged, and now it's falling off to a recoil position because it's not used to it. That means those delta theta neurons are moving up, and we're forced to go faster.
So you said that 9.8 to 10.2 is where a third of the population is going to fall into.
Yeah, so we have treated over 10,000 patients across the country.
This was concerning when you said it, so let's dig into that real fast.
So 52,000 EEGs we've reviewed. And that data set has showed us that across that population, that the average frequency is around 10. 9.8 to 10.2 is the range of about a third of the patients when they walk in our door.
So 2/3 of the population aren't in that.
True. They're they're above 10.2 or below 9.8.
Right.
It's those patients that really benefit from personalizing the dose because they're going to get a frequency that's much more in line with their existing brain.
Right.
And we're not fighting gravity. You're fighting gravity to move a 10.9 hertz patient down to 10. And when you're done, they're going to float back to 10.9, and it won't last as long. So to get therapy to last longer, we want to pick their ideal frequencies.
So basically, I mean, the huge benefit, 2/3 of the population should be getting PrTMS versus TMS.
That's how we view it. I think for a third of the population, standard TMS would have similar effects because you're within that 2 or 3 hertz range or tenths of a hertz range.
Right.
But the other thing with personalizing our TMS is we treat 5 locations.
Yes.
Standard TMS treats 1 location.
Full brain treatment.
So we're getting the full cortex activated. And we're treating areas like in autism, we treat the Wernicke's and Broca's regions of the brain.
Okay.
These are the speech cortices. And you can't do that with standard TMS. You'd cause seizure. So motor planning in our patients, motor sensory issues, pain. We can treat the motor sensory strip right on top of the head. Again, you can't do that with standard TMS. And the main reason is that we're reducing the amplitude. Meaning it's tolerable because we're turning down the intensity, but picking designer frequencies. So I'll give you one analogy of this.
I love your analogies.
If a child's on a swing and they're in oscillation, your brain's in oscillation, let's say, and I just tap the back of that child, I can keep him in oscillation with very little energy. I can barely tap their back and keep them there if they're in the appropriate oscillation,
Okay.
right? If they're out of oscillation, I have to like push them back and use energy to get them back into the swinging position. But once they're oscillating, it takes very little energy to keep it there.
Got you.
So the goal is to find the patient's intrinsic oscillatory frequency and to magnify that. And when you do that, you can pick very little energy to do so, because it's a resonance in physics theory.
Right.
You're adding like a tidal wave to their existing wave,
Okay.
right?
That makes total sense.
Yeah.
Hey guys, if you found that video helpful, do me a favor, click on this one right here. You'll really enjoy it. Did you click it? Click on it. You're going to love it.